Hello, this is Ginger Keene. This lecture is on mechanical ventilation basics. We're going to review the indications for intubation and mechanical ventilation. We're going to identify complications of mechanical ventilation, the various modes of ventilation, the nurse management of an intubated and mechanically ventilated patient, and the process for weaning and discontinuation of mechanical ventilation. The indications for intubation and mechanical ventilation, most oftentimes you'll see patients that are in a cardiac respiratory arrest, anybody with impending respiratory failure, profound respiratory depression, inability to protect their own airway, surgical procedures, unstable midface trauma, and a decreased level of consciousness with a Glasgow coma scale less than 8. That usually indicates severe brain injury. Let's first review your PPE requirements for any aerosol generating procedures, which would be intubation, is included in this, especially with all staff in the room of a patient that is undergoing investigation or confirmed COVID-19 must follow these PPE guidelines. They must wear an N95 and eye protection or a PAPR prior to performing any aerosol generating procedure. Just so you understand, other aerosol generating procedures are nasopharyngeal swabbing or oropharyngeal swabbing for testing of the COVID-19 during initial evaluation, sputum induction, open suction of any airways, tracheal intubation, bronchial scope, invasive ventilation such as BiPAP or delivery of high flow oxygen, tracheotomy, cardiopulmonary resuscitation, and nebulizer treatments. Let's talk about who intubates. It requires credentialing for intubation and institute specific. Usually they are certified by an anesthesiologist or a CRNA. You'll find ED physicians, hospitalists, certain hospitalists, not all hospitalists, your critical care physicians, some nurse practitioners and PAs that are specialized in critical care or respiratory are certified, and some institutes, their respiratory therapists are certified to intubate. For the equipment for intubation, the patient is probably already having an ambu bag and being oxygenated. The oxygen would be either from a tank or from the wall. You should turn the oxygen up to a minimum of 10 liters, up to 15 liters, in order to maintain that reservoir oxygen bag full. You would need suction. You need a whole setup of suction, fully functioning. Make sure that it's working. You would need the tonsils suction, which is your Yankauer suctioning. You would need also a suction catheter, so that if once the intubation has occurred, you can easily go down and suction any secretions that are spurring out. You would then need laryngoscopes, so you would need a handle and the different blades, which you have a Miller or a Mac. So you have the Millers are straight, and they come in different sizes, and the number would be on either the side or on the back of the laryngoscope's blades. Or you have a Macintosh, or we call them Macs, that's curved. So again, they also will have a number on the side. The provider usually will let you know what size and what type of blade they would like. Always make sure that the light is functioning. So once you attach the blade to the handle, you're going to snap it down and pull it up, and it will make sure that there's a light. If these are reusable ones, sometimes these light bulbs can become very loose and they can come off, so you'll always want to make sure that they are tight. Many laryngoscope blades are actually disposable, so once they're used, you can throw them out. but there are some that are reusable. You would need also a stylet. The stylet is to, in the endotracheal tube, to give it some stiffness so that it's much easier to handle. It'd be too flimsy otherwise. You need some water-based lubricant just at the very tip of the endotracheal tube. You do not need to load up the lubricant along the whole endotracheal tube. And just know where the location of your equipment is in your institute or even department. And also note whether there's a respiratory box versus a crash cart. Some places will have a separate intubation box. Others will have the intubation equipment directly in the crash cart. So it is important for you to know where exactly the intubation equipment is and have that ready for the provider, whoever is going to be performing the intubation. Other equipment you need is the actual endotracheal tube. So with that, you also need a 10 cc syringe. This 10 cc syringe is going to be attached to the blue port, which is going to blow up the balloon at the end of the endotracheal tube. The endotracheal tube comes in a variety of sizes, usually 7 to 7.5 for women, 7.5 to 8 for men. With the endotracheal tube, some facilities will check the patency of the balloon, other facilities may not. Just know what your policy is at your facility. You will also need an end-tidal CO2 detection device. So there's the colorimetric one that will flash color. So once it's at the end of the endotracheal tube, once the patient is intubated, the color, when the patient exhales, it will flash, the color will flash across the screen indicating that there is CO2. Or a better way is if you have a waveform capnography, which would show in this picture down here that you have waveforms. And these waveforms show that the patient is actually intubated, and that is end-tidal CO2 that is coming out. Other things you will need, or possibly McGill clamps. McGill clamps assist with, especially with nasal intubation, because they have this angle. They can be visualized when they'll take the laryngoscope, insert the endotracheal tube through the nair, and then advance it. And with the laryngoscope and the McGill clamps, they can actually facilitate the tube through the vocal cords to intubate the patient. So that's usually indicated for a nasal intubation. Other things you need is a securement device. So something that's going to make sure that that tube is not going to migrate in or out of the patient. And lastly, you definitely need a ventilator. You can only bag them for so long, and therefore once everything's been established and stabilized, usually the respiratory therapist will attach the patient to a ventilator. I just want to review rapid sequence intubation, RSI. This purpose of RSI is usually done when a patient is unknown as to their last meal. It does help lessen the risk for vomiting and aspiration, because what it does is it quickly promotes unconsciousness and paralysis. Right here we have a couple different induction agents. So you have etomidate, which is a short-acting intravenous anesthetic agent. Propofol is also a short-acting medication that results in a decreased level of consciousness and lack of memory of events. And please remember that a provider are the only ones who can administer the IV push. Nurses can start and manage Propofol infusions, but they cannot administer the IV push. Neuromuscular blockade agents, they are listed, but we're going to talk more about those towards the end of this lecture. And just remember, they have no analgesic or sedation effects. Sucks and Rocuronium are two of the most popular for RSI. And other adjunctive therapies you'll see used is fentanyl for pain management, or Versed, used to produce that sleepiness or drowsiness and relieve anxiety. So this is important, especially for the patients who have not fasted or at greater risk of vomiting and aspiration. To this, the end of the goal of RSI is to intubate the trachea without having to use a bag valve mask, or BMV, ambu bag ventilation, which is often necessary when attempting to achieve intubation conditions with sedative agents. So this will therefore decrease the increase in air that can accumulate in a stomach, and again decrease the chance of vomiting and aspiration. So to prepare your patient, you may have a different role. So preparation of the patient can vary by different roles and institutions. So determine your role at your facility regarding the patient intubation. First and foremost, you can remove the headboard and position the patient at the top and flat in a supine position at the top of the bed. Usually you can position them in a sniffing position where their neck will be hyperextended. Sometimes if it's more difficult to get a head position back in that sniffing position, sometimes taking a towel and rolling it up and placing it at the base of the shoulders, so that will help allow the head to drop back and tip back the neck. Don't forget to remove dentures. It's much easier to remove them before you intubate than after, once you have an endotracheal tube in there. You will want to make sure that the mouth is free of any kind of secretion, so we want to suction the mouth. You want to pre-oxygenate and ventilate with a valve mask device, or ambu bag with 100% oxygen. Remember, you're pre-oxygenating, you're not hyperventilating, so we don't want to breathe too fast, which will indeed cause an increase in air that's going to get into the stomach, and therefore can increase the threshold of that stomach and cause vomiting. And also hyperventilation, this can also decrease cardiac output because it causes an increase in intrathoracic pressure. But again, we'll talk about that again later. So once the patient is intubated, you want to confirm the endotracheal tube placement by observing equal chest rise and auscultating by listening for the epigastric area and the lung fields. Oftentimes I listen to the left side before the right side, because normally if you go too far down with the endotracheal tube, it goes directly into the right bronchus. However, if you have a left side breath sounds, that usually indicates that you have at least above the carina, so that you are ventilating both breath sounds. But you would listen to both sides. You would check the end tidal CO2 to make sure that it is in good placement. With waveform capnography is preferred, but you can use colorimetric. A chest x-ray, definitely need a stat portable with a reading. So the goal is for the endotracheal tube to be about 2 to 4 centimeters above the carina in adults. Some textbooks state that the ET tube should be 3 to 4 above the carina. Looking at this picture, it's actually an improper tube position with a recommendation for correct placement. So what you're looking at, the carina is the ridge of cartilage in the trachea that is between the division of the two main bronchus, the right and the left. And the idea is that this ET tube should be up higher, so that it allows air to fluidly go back down both sides of the bronchi. The goal is to ventilate both lungs. This is a chest x-ray. Not sure if you can see that there's the end of the endotracheal tube and the carina is right here. As you can see, this graying area that are branching off. This is kind of outlining your bronchial. So this is your endotracheal tube, and what we're looking for on the chest x-ray to be at least 2 centimeters, if not up to 4 centimeters above the carina. Again, the goal is for equal ventilation of both lungs. So once the patient has been intubated, there's a few things that you need to do. One of the first and foremost is find out which physician is managing the ventilator, especially if a patient came back post-op. The surgeons want nothing to do with the ventilator. The anesthesia department is done after they've moved the patient out of the OR and the patient has been recovered. So it is important to find out who will be managing the vent orders. They will be making vent changes, and they will be giving the orders for the first settings. The other thing you need to do is check and document tube position where the CM marking at the lip. So once the ED tube has been confirmed that it's in good placement, chest x-ray has confirmed that it's in good placement, it is very important to note where at the lip those CM markers are and mark that number on documentation. If you have a whiteboard in your room, it's a good idea to document where at the lip that endotracheal tube falls so that you don't have to go into the computer to try to find out where it's supposed to be when you come on your shift. It's a good visualization for other nursing staff that are coming in to make sure that they know that their endotracheal tube has not migrated in or migrated out. So definitely want to make sure that you have confirmation at the lip that it's in this proper place. And in order to keep it there, we need to have some kind of tube securement device. We want to document the vent settings. So the first set of settings, you definitely want to note in your nurse's note what the settings are. You are definitely going to want to obtain vital signs and pulse ox, and you're going to monitor that patient. And I want you to understand that you're going to see hypotension and anticipate that. And you can treat that hypotension with a fluid bolus. Patients who are intubated go from a negative pressure to positive pressure. So therefore, that positive pressure is increasing intrathoracic pressure, which can actually cause a decrease of blood return back to the heart and therefore decrease cardiac output and cause hypotension. It takes a little while for the body to readjust to that change in pressure, but in the meantime, if your patient is hypotensive, you can give them fluid boluses to correct that. You want to also note that if the patient is decreased work of breathing and any kind of medication effects, consider the need for restraints. Most patients who are hypoxic are oftentimes restless and they don't really know what's going on, and they will reach and try to pull out the endotracheal tube. If you've gotten your patient adequately sedated, they should be okay. But again, if you are concerned that the patient's going to be pulling out their endotracheal tube, use restraints. Also, give them opportunities not to be restrained. So if you're in the room working, doing an assessment, unrestrain the patient, let them move their hands around. If they are looking like they are going after their tube, then yes, keep them restrained. But if they're just moving their arms a little bit, that does help allowing them some range of motion. Other things you can consider, if there's a family member in with them, if they can consider watching the patient, making sure that they don't extubate. Usually but the patient oftentimes will be restrained, and again, just kind of use guidance as to what the patient really is doing and what the need is. Other things you need to do is review your ABG results. You're going to get ABGs before you even intubated the patient, indicating that the patient needs to be intubated, but you also need to review the ABGs after the vent was set up, and then every time the ABGs come back, you will need to notify the doctor and the respiratory therapist if there's any changes that need to be done on the vent settings. So there probably is going to be a need for medication, an analgesic, because that tube does hurt. And just sitting in the back of your throat, it can be irritating. It's good to have sedation, and that helps with the synchrony of the patient with the vent. If the patient is not able to get adequate synchrony with the vent and consistently is bucking or biting or fighting the vent, then they may need to have a neuromuscular blockade. And just remember, ABGs are not the only assessment of respiratory status. Be familiar with your institution and your physician's practice related to obtaining ABGs and actually how often they are being obtained. Monitoring saturation and consider that there are some times that saturations are not adequate, because if a patient is hypotensive, if they're on high levels of pressors, you won't get a good saturation, or at least a true saturation. So be aware of that. Unfortunately, with any intubation, there's always potential for complications. Vomiting with aspiration is one of those complications. Intubation of the right main stem bronchus. So that can be, you would have your left lung would not be adequately ventilated and can become atelectic. That's why it's very important to make sure that you're listening to bilateral breath sounds and noting the position of the tube, so that if it does happen to migrate down, it's going to usually migrate down into the right main stem of the bronchus. Other things, trauma of the oropharynx, the nasopharynx, the teeth can be chipped or lost. Vocal cords can be damaged. They can develop arrhythmias such as Brady. They become cardiac arrest. They usually will go hypotensive. So these are all things that can happen with intubation. So being prepared for that is very important. Now, if things don't go as planned and you have a very difficult intubation, you have other ways that you can, other means you can use. Usually it's about 30 seconds approximate time for each intubation attempt. The goal is for one attempt, and we do document how many attempts it takes for a patient to be intubated, and respiratory therapists keep data on that. So the resources that we can use for those difficult intubations, the first one is an LMA. This is laryngeal mask airway. It is considered a supraglottis airway. It is a temporary measure. Usually, often in the OR that's used, so for short cases, sometimes they have some LMAs that can be intubated if the case becomes longer, so they can actually migrate and put a endotracheal tube through there, or a stylet to allow an endotracheal tube to be intubated. Another method is a Glidescope, which is provides a visual aid on a monitor and allows much better visualization of the vocal cords to allow intubation on that. A Bougie is a primary use for those real difficult intubations when you cannot see the larynx well, but are able to predict where the glottis opening is based on the anatomy. And then you would load the endotracheal tube into the Bougie, and then once it's in, they call the action railroading the tube down the Bougie, presumably because the tube is following the track into the target. If that fails, there's other things such as a nasotracheal intubation, and that is more of like a bloodbath. That is very traumatic, but you use a much smaller endotracheal tube. But if you do have like some kind of maxillary fractures, then you would use that. A tracheostomy is making an incision in through the neck, through the trachea, and to assist, and you can put a trach tube in there, and that will assist with breathing, and the upper airways are blocked, or you're unable to get a patient off of the ventilator. Another way, which is in an emergency, is a cricothyrotomy, which is an incision through the skin, through the cricothyroid membrane to secure a patient's airway for emergency relief of upper airway obstruction. The primary difference is that a trach is lower in the trachea, and a cricothyrotomy is usually done in an emergent situation when you are unable to intubate someone and need to get access to someone's airway in a hurry. It's done through the cricothyroid membrane, through the Adam's apple, and their landmarks are much easier to identify, and you avoid the vocal cords and the person's thyroid gland and associated vessels. One thing that is important is patient and family education. Even though once a patient is intubated, you can't really give them a whole lot of education, but prior to the intubation, you should be able to remind them that they will not be able to talk, that they may be restrained. But again, if anything, you should be telling the family, explaining to them why the patient can't talk, to remain calm, establishing a different method of communication, and when the patient can communicate, when their ability to write things or type things out on a phone. Other things that you may want to explain to them is that why they have to be sedated and why they can't be awake because they don't breathe with the vent very well. So these are things that you need to help them understand of why we're sedating them. We're feeding them maybe through a G-tube or OG tube. So now let's focus on mechanical ventilation. Please understand there's a difference between how normal ventilation when you're without a ventilator and when you have an actual mechanical ventilation. You have different pressures. With normal ventilation, your spontaneous breathing is based on negative pressure ventilation. And just to kind of give you an overview with this, if your diaphragm is normally concave, it's a muscle, once it contracts and it pulls downward, just like this bottle here, when it's pulled downward, it creates negative pressure within the lung or intrathoracic pressure. So therefore, what it does is it causes the lungs to inhale. During exhalation, it's a passive movement, so when the diaphragm goes back up, then the air is exhaled. But primarily, your spontaneous breathing occurs through negative pressure, and the pulling of the diaphragm down creates that negative pressure within your pleural. Now let's talk about positive pressure ventilation, which is mechanical ventilators deliver positive pressure ventilation. This is a mixture of air and oxygen pushed through the tube into the lungs. So what does that do? It creates a positive intrathoracic pressure, which includes positive intrapleural, positive airway pressures, positive intraalveolar pressures. There will be also some complications due to this positive pressure, which we'll talk about later, but understand that these are all things this is the difference between normal breathing and mechanical breathing, is how the pressure is, negative pressure as opposed to positive pressure. So the choice of modes is based on a couple different things. The disease process, the brand of a ventilator, not all ventilators do everything, your physician preference, treatment goals, patient's ability to ventilate, and how much support they require. Now let's talk about the different types of ventilator modes. There's volume versus pressure. Let's talk about volume first. In volume ventilation, there is a preset tidal volume. It means that it's the same volume of gas is delivered with each mechanical inspiration. The tidal volume is always constant, the same. The ventilator will deliver the same amount of volume regardless of how much pressure it takes to deliver that volume until the high pressure alarm limit is reached. A set pressure is prescribed And that is when the ventilator will pump gas into the lungs in pressure ventilation until the preset pressure is attained. So this is with pressure ventilation. The peak airway pressure is constant, but the tidal volume is going to be variable, and that's going to be based on the patient's lung compliance or resistance. So if you can imagine the lungs being like a brand new balloon, if you're trying to blow up the balloon and it's very tight, it's very resistant, it has very low compliance, it takes a lot of pressure to blow up that balloon. So this is how much pressure is going to be. So the tighter the balloon, the more pressure it requires to get the adequate amount of volume in there. However, if the more you blow up that balloon over and over and over again, the compliance will decrease, therefore making it much easier and less pressure to blow up that balloon. So when we talk about pressure or compliance and resistance, we think about the balloon and how much pressure it takes to get the amount of volume, the same amount of volume, as opposed to a balloon that is, been used over and over again. It's much less resistant and a lot easier to ventilate or put volume in it. So with pressure, comparing volume ventilation and pressure ventilation, it's a matter of volume will be a set volume will be delivered until it meets that highest pressure, where pressure ventilation will have a set pressure. It will not allow the pressure to go any higher than that set pressure, and it'll continue to give gas until that pressure is met. But your tidal volumes are going to be varying depending on how resistant your lungs are. The advantages and disadvantages of volume ventilation. So let's talk about the advantages. Because we are giving a set tidal volume, we have a guaranteed tidal volume. We also have a guaranteed minimum respiratory rate. Most generally, you'll have settings that allows the patient to go above that rate. But with a guaranteed tidal volume and a guaranteed minimum respiratory rate, you're going to get a guaranteed minimum minute ventilation. And with that, that's going to allow your patient to have adequate ventilation. And we talk about ventilation in regard to blowing off CO2. Without adequate ventilation, whether in volume or rate, you can't rid the body of CO2. The disadvantage about volume ventilation is that with that increase in volume, if you have very resistant lungs, that's going to cause a lot of barotrauma if there's a lot of pressure in there. So unfortunately, with the higher airway pressures, you can have more damage to the alveoli. There's also a risk of potential breath stacking. So that means breath, depending on the rate, but with breath stacking in an artificial respiration is incomplete. So what happens is your patient is taking breath, or the ventilator is giving a breath, and if the breath is not allowed to be exhaled all the way and it starts giving another breath, what's happening is that some of that air is going to stay trapped in the airways, in the lungs, and it's going to cause eventually overinflation of the lungs. With each of these, that can also cause barotrauma and air trapping. Now let's talk about the advantages and disadvantages of pressure ventilation. So the advantages of pressure ventilation is that it does have limited peak airway pressures, which therefore, if there's not a whole lot of pressure going into the alveoli, then you're going to have a decreased chance of barotrauma. However, with disadvantages, if you have very resistant lungs or very low compliance, what's going to happen is it's going to take so much pressure to try to fill those lungs, and if you have a maximum amount of pressure that you're only allowing to push the air in, you're going to have lower tidal volumes and a lower minute ventilation, and it's going to vary. So why do we care if the tidal volume varies? Because minute ventilation equals tidal volume times respiratory rate. A normal minute ventilation while resting is about 5 to 8 liters per minute, and it does increase with exercise. If the patient reaches that preset pressure with a small tidal volume of 200, then their minute ventilation will be inadequate, and therefore what will happen is the patient will not be able to blow off CO2. So the rate or pressure may need to be adjusted. And just to give you an idea, again, the minute ventilation is the tidal volume times the respiratory rate. Usually your tidal volume is about 500 times, let's say, 12 breaths per minute. That equals 6,000 milliliters a minute. And in increasing the respiratory rate or tidal volume will increase your minute ventilation, and this will directly affect your CO2 and how much is blowing off your CO2, or how much CO2 is being retained. So with this, we're going to show you the different ventilator settings. So as we progress the higher level settings, you primarily should know these key settings. So the respiratory rate, there is a set respiratory rate, and you should know what that set respiratory rate is so that you can also determine how much the patient is breathing over the vent. This usually will be allowed to, the vent usually will be allowed to initiate a breath according to the sensitivity set by that respiratory therapist. It's almost like the respiratory therapist will set so that the patient can allow them to take certain breaths, and that would be probably a setting that you wouldn't realize what it is, but it is set that so that the patient can breathe in addition to what the preset settings are. Typically, you'll see a respiratory rate 10 to 20 breaths per minute. So your oxygen concentration, your FiO2, that's the percentage of oxygen being delivered to a patient. Your FiO2 is the abbreviation for fraction of inspired oxygen. And typically your oxygen level is 21% room air to 100%. The goal is to adjust the FiO2 or to keep the saturation greater than 90% and your PO2 greater than 60%, 60 millimeters per. But again, you should review your hospital policy for the RT's ability to make adjustments according to the saturation. The goal is to maintain the adequate saturation with the minimum amount of FiO2, so therefore you do not cause any oxygen toxicity. The tidal volume, you may also see it as VT, which is the volume of gas delivered to the patient during each ventilated breath. So this can be measured in milliliters. Typically, you'll see a setting set 5 to 8 milliliters per kilogram of ideal body weight. So the tidal volume should be about 10 to 12 milliliters per kilogram, but most use 5 to 8 as lungs protective strategies, most patients. This helps to protect the patient's lungs so that there's no barotrauma. So the person who can make ventilator settings in the institution is also something that you should also know. And many people refer to the respiratory therapist for guidance as to what settings and how the patient tolerates it. The last setting is PEEP, positive end expiratory pressure. Positive pressure maintained in the lungs throughout the expiration phase. So this means when the patient has exhaled, they're still going to maintain a level of pressure within the alveoli, within the lungs. And what that does is that it helps maintain the alveoli to stay open. And especially if you have very acute respiratory distress syndrome, ARDS, those patients have very resistant lungs and they're very stiff. And every single time that you try to give a breath to those alveoli, they're very hard to open. So it's almost like every time the patient would exhale, you have to start all over again. Where with PEEP, if you maintain just a little bit of PEEP or different levels of PEEP, If you keep the airways open just a little bit, the next time the next breath comes, it's a lot easier to open that alveoli. So it kind of gently nudges them open, and keeping them open, it also will help with recruitment of alveoli that are not affected by acute lung injury or ARDS, so that it will utilize the good lung tissue to be open longer and promote more diffusion of your O2 and CO2. Your typical settings for PEEP are 5 to 10, but it can increase to settings as high as 20 centimeters of water in patients that have acute lung injury or ARDS. And that is very you have to be very cautious with those patients, because those high PEEP settings can cause extreme barotrauma and can cause the patient to actually have a pneumothorax. So be very cautious with patients that do have PEEP. And they also, with PEEP, can cause hypotension because you are increasing your intrathoracic pressure as well. So a couple more other settings. So pressure support. This is a positive pressure used to augment the patient's inspiratory effort. So this is typically used when you're in a weaning setting or a intermittent ventilator setting where the patient can do some efforts, and it does help that patient to overcome the size of the tube with just a little pressure. That setting is usually typically 5 to 10. And then there is the peak inspiratory pressure, the PIP, if you want to say. But this is the highest pressure recorded at the end of inspiration. And so high pressure limits the maximum pressure the ventilator can generate to deliver the tidal volume. And when the pressure limit is reached, the ventilator terminates the breath and spills into the undelivered volume into the atmosphere. So typical settings for your PIP, your peak inspiratory pressure, is 10 to 20 centimeters of water above the PIP. So your high pressure setting is usually 10 to 20 centimeters of water above the PIP. And again, the highest level of pressure applied to the lungs during inhalation. Couple more settings, your inspiratory flow rate time. So this is the speed at which the tidal volume is delivered. The flow rate is usually, again, how fast the flow of volume is going in and over what time it's going to take to get that in. So this can be done by the respiratory therapist as according to how the patient can tolerate it. And again, it also depends on the lungs, how compliant they are. So normally you breathe at inhale, we'll say 1 to 2, and you inhale a second and you exhale 2 seconds. So usually it takes less time to inhale than it does to exhale. But we can also change that time for inhalation and exhalation so that it allows more time to inhale or to deliver that volume so that you can more adequately get and meet that tidal volume goal. So this allows more time to get that volume in, and it can be adjusted accordingly. We talked a little bit about sensitivity, and this is the amount of effort the patient must generate to initiate a ventilator breath. So the IE ratio, we talked a little bit about inspiratory flow rate and time. So this is usually, again, the typical setting is 1 to 2 or 1 to 1.5, and this is the ratio of duration of inspiration to the duration of expiration. So in conjunction with the inspiratory flow rate and time, you're going to the respiratory therapist can schedule how much the ratio between the inspiration and the expiration. They can actually even flip it so that it takes more time to inspiration than it does expiration, which is the opposite. In some cases, that works better for patients that, with certain lung conditions. So your physician orders will provide these parameters, And nurses usually are responsible to know all these settings, and the respiratory therapist is responsible to knowing, and setting these and more. So we talked about the sensitivities, the IE, the flow rate. So you may, as a nurse, not know all of those, but the ones you should know is that you should know the mode, whether it's a volume or pressure or a combination, the tidal volume that is set, the FiO2, the respiratory rate, the PEEP, and if the patient has some pressure support. So those are the settings that the nurse should know and have documented. So there are a wide variety of modes of ventilation. We're going to discuss the levels of ventilator support that we will discuss in the most common modes. So there's different variations that the ventilator will assist the patient to, and we'll kind of compare it to pull-ups, I guess, or a breath. So full support, the ventilator is doing all or most of the work of breathing. So with intermediate support, the patient's doing some work, but the ventilator will help. And if the patient cannot do adequately enough breathing to sustain adequate minute ventilation, then the ventilator will also take over. Usually with an intermediate setting, there will be lower respiratory rates that will be fully supported, and then the patient, when they take their own breath, it's pretty much their own breath, their own volume. However, the patient will have opportunities to have some support, like pressure support ventilation, so that it's not so hard to pull in that air. Then there is weaning, where the patient is doing most of the work. They can basically, they're doing all the triggering of the breathing. The only difference is, instead of them trying to pull in the air all on their own, they will get some positive pressure to decrease that workload so they don't get tired too early. So the levels of support, of ventilation support, and again, it depends on the type of patient requiring full support. So no respiratory effort, and they need rest of work of breathing. So those patients usually include overdose, anesthesia, chemically paralyzed. They need to rest in the work of breathing. So if they've fractured ribs due to trauma, acute lung injury, severe asthma, so these patients would require full support ventilation. The most common level of ventilator support until the patient is ready to be weaned is a intermediate support. So as the patient's we're trying to pull the support back a little bit, you'll notice that there is a repeat in certain conditions like ventilator modes, but not one size fits all. So different types of patients requiring intermediate support. So they may be able to breathe on their own, but they just need a little bit more support, such as neurological disorders. So they do have irregular breathing due to changes in their, increased cranial pressure. So head injuries, so they may have erratic breathing and they need to have just a little bit more support. Overdoses, COPD, CHF, and milder cases of acute lung injury, or if they've had acute lung injury and they're starting to be weaning off so that the patient can do more on their own. So these are, and some trauma. So these are patients that would require intermediate support. And what that entails is you will get the ventilator setting will give you some full support, a minimum amount, not as much as the full support, where you may have a breaths 4 to 5 a minute, and then the patient is able to, the sensitivity will be decreased so that the patient can trigger more of their own breath. And when they trigger their own breath, they're actually getting some pressure support to help push air in so that when they're pulling in, it's not so hard to try to pull in through the endotracheal tube, which is almost like breathing through a straw. So we don't want them to get tired, but we do want them to work a little bit because they have their diaphragm, if it's not used, it can atrophy. So we do want patients to exercise some as before they can completely wean off a ventilator. Now the weaning modes, this is a support that is all patients will need to go through a weaning process to effectively come off a ventilator. So it's slowly pulling off full support when you go to intermediate support, and a weaning is not completely taking them, extubating them, but allowing the patient to practice breathing on their own with a little support. So let's talk about the different types of ventilation modes. So this is ACES control. This is typically referred to as a volume control. But you may hear that referred to as ACES control. And the ventilator settings vary from mode to mode, but for ACES control, these are primary settings that you're going to focus on. It is a full support, means that the ventilator is doing all the work. It is a resting mode, meaning that the patient was doing the work in the different mode and is being put on ACES control to allow the patient to rest. Usually with this patient, the patient that is resting, they recover from some insult such as a rib fracture or they had surgery, but this usually has fairly good lung compliance. These patients usually don't have restrictive lung compliance and are able to be ventilated, and those are the patients that work best on ACES control. It does provide controlled ventilation. In the absence the patient initiates a respiratory effort, the ventilator will deliver a controlled breath. So this means if the patient triggers their own breath, that breath will be fully supported. So whatever the tidal volume that was preset, so that patient will get the tidal volume that was preset at the FiO2 and the PEEP that was all preset. So the patient can breathe faster than the preset respiratory rate, and those triggered breaths will also be fully supported. The volume control mode shows a delivery of preset tidal volume with a preset respiratory rate, and expiration begins when the preset tidal volume is delivered, or if the high pressure limit is exceeded. So again, this is considered a full support mode. With a pressure control parameter, this delivers a preset pressure. So you have a constant pressure delivering air into the lungs, and the ventilator will pump gas into lungs until that preset pressure is met. And that peak airway pressure is constant, but the tidal volume will vary, and that's based on the lung compliance or the resistance. So it also has a preset respiratory rate. The patient can breathe above what the set rate. You also will have PEEP, and you will have an inspiratory time. Now, if you have very resistant lungs, and if you keep trying to push in air at a set flow rate, you may not be able to get adequate tidal volumes. So what the respiratory therapist can do is adjust the inspiratory time so that it takes more time and a lower flow rate until that peak inspiratory pressure is met, and therefore hopefully you can get better volumes, because again, the key thing is you have to get adequate minute ventilation in order for you to blow off CO2. But what you're also going to find is a variable in your tidal volumes. They're going to vary from one breath to another breath, again, according to the resistance. In this slide, we're going to use waveforms to demonstrate the difference in flow, pressure, and volume according to lung compliance. So the first one, where you have low lung compliance, which means that you have very resistant lungs or stiff lungs, and is very hard to ventilate. So the pressure, airway pressure is the same, but you're very resistant to try to get the flow in, and you have very low tidal volumes because the lungs are so restrictive, or stiff. And as you compare into the second one, this is within normals. So then if you're looking at the high compliance, which shows, again, the same pressure, so how you deliver, you get higher tidal volume. It's very easy to blow this balloon up. It's been used over and over and over again, so it's very easily. So you have a easier flow rate. And again, it's usually due to the overextended alveoli that can hold in more volume. So this is just a little bit of a graph to or waveforms to kind of give you a visual as to the difference between how flow and pressure and volume affect with the different types of lung compliance. So in this mode, you have pressure regulated volume control. We call that PRVC, which oftentimes you'll see a lot of patients on. So it provides a controlled ventilation in the absence of patients, doesn't initiate their respiratory effort, and the ventilator will give a controlled volume. So with this combination of pressure and volume control, it delivers that preset tidal volume with a preset respiratory rate, and a preset tidal volume is delivered at the lowest possible pressure, or a preset pressure. So they will be upper pressure limits, and so what you'll see is down below here on the bottom is the settings of the ventilator. On the side here is the patient's settings. So this is what the patients are doing. So let's look at what we're looking at. So right here we have tidal volume. So the tidal volume is pretty constant, and it's meeting, what you'll see is the FiO2, so this is how much oxygen is being delivered. You also have your respiratory rate, so it's set at 15, but the patient is doing 17. So they're breathing a little bit over the vent, which is usually fine. And we have a PEEP. So again, if you're looking here, this is our setting of PEEP. Right here, it looks like about 4. And if you can see right here, this is where your, where your PEEP is. I have to erase all that. So what that is doing is giving you the positive end expiratory pressure. The next thing we're going to look at is your inspiratory time. So this is how much time that you're in the flow rate of what you're delivering the air in. And you can see that there is a IE ratio of 1 to 2.1. So it's taking 1 second to go in, 2.1 seconds to come out. And the other one you're going to see is your peak inspiratory pressure. And that is how much the limit of what the peak inspiratory pressure is being delivered. And that's this pressure right here that you're seeing. So that was assist control and PRVC, and this is synchronized intermittent mandatory ventilation. We call this SIMV. So again, this is more towards a combination of giving the patient controlled and spontaneous ventilation, so giving them the opportunity to breathe some on their own. So this will deliver a preset tidal volume or pressure with a preset respiratory rate, and you can use this with PRVC as well. So it has a preset tidal volume or pressure, and then the patient can breathe spontaneously between the machine breaths. The patient receives the machine breaths that are synchronized with his or her own breath efforts. So with that, when the patient does breathe on their own, it gives them a little bit of, we call it PSV support, pressure support ventilation. So this is important because the patient, when they do PRVC, PSV or PRVC and they need a little bit of support, when they're breathing on their own, we want them not to feel like they're trying to pull in so much air through like they're breathing through a straw. So this PSV will give them a little bit of support so that they can, it's almost like a blowing of air so that they can inhale without so much effort. And there's usually always PEEP. And like I said, you'll usually have lower respiratory rate settings. So again, that'll be depending on what the patient can do. But the lower respiratory rate settings will allow the patient to breathe on their own, and then that will help exercise them and maintain an adequate diaphragm so that they can breathe when they are able to come off the ventilator. So with the pressure support ventilation parameters, so this is PSV, so this is a weaning. So you have this pressure support level, and it usually is between 5 to 20. The patient's able to breathe on their own. They have to be able to breathe on their own, but this is supported. So they will have a delivery of FiO2, and they also will have PEEP. PEEP is good because we want patients to maintain their alveoli open and not collapse completely. So usually you'll start with a PSV higher, and again, so it can help the patient so that they don't get too tired, and allow that as soon as you come down on the PSV, it slowly brings them to the point where they're at a level as if they're breathing on their own. So again, all their breaths are spontaneous, and their rate will be variable as well as their tidal volumes. So that since it is considered a weaning mode, we definitely want to make sure that you monitor your patient. They should not be on sedation when they're doing this. This is preparing them to be extubated. CPAP is a continuous positive airway pressure setting, so similar to PSV. So there is a FiO2 setting, so obviously, and a CPAP level, which is the pressure that is going to be continuously pushing air through the endotracheal tubes. And they also have apnea parameters, which is very important. So if the patient, again, this is a weaning mode, so if the patient stops breathing, you would be alerted to that. So airway pressure release ventilation, they call this APRV. Patients tend to be more comfortable with this setting because they have unlimited spontaneous breathing ability and have less effect on the cardiovascular system because less positive pressure pushed into their air. So what this is a regular spontaneous breathing maintains diaphragmatic muscle conditions, so this is good for those patients to maintain their diaphragm. Patients have the ability to maintain their spontaneous tidal volumes with unrestricted flow patterns. And the longer the inflation time, the greater the lung areas potentially available for gas exchange. And it's similar to BiPAP's concept of different pressures for inspiratory and expiratory. And both modes allow unrestricted spontaneous breathing both during and between mandatory breaths. But there is more time for them to occur during the mandatory breaths with APRV. And again, APRV typically uses extreme inverse IE ratio, while BiPAP usually does not. So the spontaneous breathing can occur both during and between mandatory breaths. So they have usually, like I said, the inverse ratio that is different. So the TPs. So patients no longer on a ventilator, they just have the endotracheal tube, and it is attached to this T-piece, and attached to humidified oxygen to the wall. The challenge with that is that the patient does not have any alarms to alert you if the patient is in distress or if the patient is apnea. So T-pieces are usually not the ideal to try to wean somebody. It's pretty old school, but the one good thing is they still have their artificial airway in place, and it can be easily returned to the ventilator. Let's talk about those ventilator alarms. So, we cannot stress enough that you always respond to a ventilator alarm immediately. You want to treat that patient, okay? If ever in doubt of what's going on, you don't understand why it's alarming, disconnect the patient from the vent and start bagging them with oxygen with the ambu bag while you're waiting for the respiratory therapist to come. So go attend to any ventilator alarms. So if we have a ventilator alarms, here's the causes. So your high pressure alarm. So your high pressure alarm rings due to something is interfering with the ability of the machine to deliver the breath. So it's being restricted. There's too much. It's requiring the ventilator to put in a lot of pressure to get air into them. And it usually is due to something obstructive or restrictive. So such as kinking of the tube or the patient's biting it, secretions that need to be suctioned. Patient may be bucking the ventilator, pulmonary compliance changes, bronchial spasms, pneumothorax, patient is trying to talk, and so they're trying to push against it. So these are things that would cause a high pressure alarm. Low pressure alarm rings when the machine detects lower than the set pressure somewhere in the system. So there is a leak within the system or a disconnect. So your low pressure alarms will go when there's patients detached from the endotracheal tube, the ventilator to the endotracheal tube, if the cuff is deflated, or if there's somewhere in the circuit there's a leak. Again, normally start from the patient and work your way to the vent. And if you cannot figure it out, make sure that you disconnect the patient, put the oxygen on and ambu bag them and call respiratory stat. Low exhale volume usually means the pressure exceeding the high pressure limit, and it could be the cause, and where you're losing volume somewhere, and the cuff leak or the ventilator is disconnected. So those are causes for your ventilator alarms and why you would have it. So if you have a high pressure alarm, find out if the patient's biting down, if they have a pneumo, or if maybe they are going into ARDS, or they need to be suctioned. And low pressure alarm, look for a disconnect. And the same thing for a low exhale alarm, volume alarm. So just find out if there's any kind of disconnect or a cuff leak. Other ventilator alarms, so an apnea alarm. So if your patient is weaning and they're on a PSV or CPAP, you would definitely want to make sure that you alert if the patient's not breathing anymore, they need to go back on their full support setting. Other things that ventilator is inoperative, so loss of power to the ventilator or a malfunction of the ventilator system. So if you've had a generator, sometimes you have downtime where your generators will kick in. All your ventilators should be plugged into the emergency generator outlets. And if you ever have a surge or a loss of electricity, usually there'll be like a blinking and then the generator kicks on. So you should always check your vents after a loss of electricity. And when your vent comes back on, make sure all the settings are correct, make sure your patient's doing okay. So that's usually a good practice to always go check the ventilator if there's been some kind of electrical surge and the generator came on. So let's talk about the complications of positive pressure ventilation. So barotrauma is one of them, and with barotrauma, you can see from this picture, you have normal alveoli. So if we're giving so much volume that we're extending or expansion of those alveoli, it eventually, especially if you have high levels of PEEP where you keep so much pressure left in the alveoli at the end of expiration, then what can happen is they can cause rupture of the alveoli, and then blood can get into there, so in causing a pneumothorax. So barotrauma is one of the complications, especially on high levels of PEEP, usually greater than 10. You should be careful and monitor your patient. Obviously, VAP, so we have many, your ventilator bundle to prevent ventilator-associated pneumonias, good mouth care, and keep secretions out of the back of the endotracheal tube. So we always want to make sure that and keep their head of the bed up. So these are all things that we want to make sure that we can follow to decrease the chance of VAP. Oxygen toxicity. So with oxygen toxicity, the pathological response of the body for long-term exposure to high concentrations of oxygen causes a problem because the cellular changes causes congestion and inflammation of edema. So when high levels of FiO2 are administered, it can cause a nitrogen washout, and nitrogen is required for the type 2 cells within your alveoli to produce surfactant. And surfactant is required to maintain your alveoli to be inflated. So it is important that as soon as the FiO2 can be lowered, by monitoring the saturation, that we should be lowering the FiO2. And hemodynamically unstable instability. So positive pressure ventilation increases intrathoracic pressure, which decreases venous return or preload, and therefore decreases cardiac output. And you oftentimes will find these patients hypotensive, so you're going to definitely monitor for hypotensive, especially on the early parts of intubation, or if you go up on their PEEP, that will also increase intrathoracic pressure and can cause hypotension. So once you have given them volume and they are adequately volumized, then you may have to consider a pressor. So therefore, but volume first before you can press it. So there's also complications of the ET tube prevention. So we have, if you have a tube obstruction, it could be due to the patient biting, so you would want to make sure that you have a bite block in. Or if they are coughing a lot, they have a lot of secretions, you may have to suction them, but suction them PRN, and humidification so that any secretions are more liquid. Tube displacement, there's using a securing the tube with some kind of device, and absolutely monitoring the tube location. So marking on a whiteboard where the CM is at the lip. So on the endotracheal tube, there are markers that you would note what number it is at the lip. Self-extubation, unfortunately, that can happen. The patient does it themselves, or if it accidentally comes out with turning, but we do want to try and sedate the patient to prevent them from trying to extubate themselves, and we use restraints if needed. Sinusitis, that can be avoided if it's avoid nasal intubation. And also, don't put an NG tube down, put an OG tube in, because NG tubes can cause a sinusitis as well in about 3 days after insertion. A tracheoesophageal fistula, that can happen because of high pressures within the cuff, so we want to maintain a minimal amount of air in those cuffs, just enough so that of cuff pressure so that it doesn't allow an air leak, and some facilities will require a monitoring of the cuff pressures. And then there's laryngeal stenosis, so with that you may have to consider a tracheostomy for prolonged intubation. So if the patient has a trach, again, there's always a potential for infection, hemorrhage, subcutaneous emphysema, tube obstruction, tube displacement, tracheal stenosis. So again, one of the biggest things is always keep an extra tube at the side, at the bedside, and use the appropriate size, the same as what the patient has in. You should always have a stylet there. Gently suction them, restrain as needed. Once they're trached, usually they are pretty good. Securing the tube and making sure that the ventilator tubes are not pulling on that trach to dislodge it. And again, you're going to also want to monitor those cuff pressures as well and do routine stoma care. So suctioning should be done PRN only, or as needed, not on routine schedule, because there are many complications of suctioning, such as usually you would the indications that would require suctioning is if you have a lot of coughing and you can actually see secretions coming out of the endotracheal tube. You're listening to the patient and you can hear or auscultate the rhonchi that are, or the coarse crackles that can only be cleared with like a cough. If the patient's in respiratory distress due to these secretions, the saturations are dropping and you're unsure why, or you have very high peak airway pressures. But the causes, the complications can be hypoxemia, dysrhythmias. If you continue the suction and they're not getting adequate oxygen, they can go bradycardic. It can cause trauma within that airway. It causes increased intracranial pressure. It can cause bronchospasms and atelectasis. So we would only want to suction as needed. So to prevent those complications, hyperoxygenate, prevent hypoxia. So hyperoxygenate, use a lower suctioning level, so less than 120 milliliters of mercury of suction, and suction less than 10 seconds and only suction on the way out. Do not instill normal saline prior to suctioning. You do not want to put any normal saline down the endotracheal tube and into the lung. It does nothing but can cause infection, because bacteria that was in the front of the endotracheal tube is now going down into the lung, and that can cause a VAP. We now have these closed tracheal suction systems, which have been around for quite a while, 20 plus years. And they are suction catheters in a plastic sleeve that attaches directly to the vent tubing. It allows the patient to be suctioned while remaining on the vent, which the advantages of that is the patient maintains oxygenation, and there is a little button on the ventilator that says 100% O2. If you press that before you suction somebody, it will blink and it'll give 100% with like 1 to 2 minutes. And also during that time, not only is it getting the patient able to get oxygenated, they're also able to maintain PEEP during suctioning. So this all will help reduce the hypoxemia. It also helps protect the staff from secretions. When you're trying to suction somebody endotracheal tube without this closed system, secretions can become airborne. So these are great things. So patient is not able to speak, obviously, so be very considerate when you're in with a patient, and if you're with another coworker and talking around the patient, just because they can't communicate doesn't mean they can't hear. So be very cautious of what you're saying and how you're saying. You should talk directly to your patient and explain to them everything you're doing, even if you don't think they can hear you. It is a good nursing care to do that. There are different interventions to facilitate communication. If you're able to lip read, it's usually one of my worst ways to try to figure out what they're saying, but better off nodding or eye blinking to yes or no questions. If they can maneuver their hand to writing something on a paper and pencil, on a paper, or with a pencil and paper, or if they have a picture board, sometimes a computer device or an iPad if they can type. So whatever their level of sedation and their ability is, offering them different ways to communicate is very important. If the patient has a trach, they may have a cuffless trach or they may have a cuffed trach, but this is another way for them to communicate. So with a Pessimir valve, the patient is allowed to speak. If the patient does have a cuff, it must be deflated, and usually it's used for cuffless trachs. But the mechanism of action is the one-way valve opens upon inhalation and allowing air to enter the lungs through the trach tube and closes upon exhalation, forcing the air over the vocal cords and out the mouth, permitting the patient to speak. The patient must be able to tolerate it, and if the patient's on a ventilator, the tidal volumes must be increased to compensate for that leak. So there's a lot of collaboration between your respiratory therapist and your speech therapist when they're using a Pessimir valve. It's not meant to stay on the patient all the time. It's usually reserved for those times that the patient wants to communicate with either family or the doctor or the nurse, but it's not meant to stay on all the time. So let's do a little review of the ventilator bundle. So the first thing is your head of bed. Again, 30 degrees or more, so no less than 30 degrees, between 30 to 45. Use the tool for the actual degree measurements, such as the little ball that's on the side of the bed, and that'll show you the actual head of the bed in the degrees. This will help decrease risk of aspiration of gastrointestinal contents and oral secretion and nasal secretions. Then there's the daily sedation vacation, and this means that you're assessing daily the patient's readiness to be extubated. So you need to lighten up on the sedation. You should have a hospital protocol for specific guidelines like this, and you want to coordinate with the respiratory therapist for spontaneous breathing trials. So this should be done daily, unless your patient's severely hemodynamically unstable. But every day the patient's on a ventilator is every day we're trying to get them off a ventilator. As soon as you intubate somebody, the goal is to get them extubated. So again, because not that it's direct with the ventilator, but peptic ulcer disease prophylaxis, DVT prophylaxis are both things that every critical care patient really needs to have. Again, the stress ulcers that are most common cause of GI bleeding in ICU patients. So these are things that you definitely want to do. And of course, deep vein thrombosis, because they're not moving, they're in bed unless you're getting them up. So they may include anticoagulants on the mechanical compression devices, depending on the patient's risk for bleeding. Daily oral care with chlorhexidine. There's usually these nice little oral care of chlorhexidine packets with 0.12%, which gives you the opportunity for brushing the teeth, swabbing, moisturizing, and usually there's a packet that's a 24-hour packet. Once this 24-hour packet is done, you can get another packet for the next 24 hours. So these are meant to be used throughout the day in a 24-hour period. You may have your own specific routine at whatever hospital based. Additional ways to reduce VAP is having an endotracheal tube with a subglottic suction. Not all endotracheal tubes have it, but what it does is this allows a little area at the base of the top of the balloon. It comes out and it goes to a suction source, and it'll take all the secretions that can accumulate there. Now, the patient's endotracheal, the cuff, even though it's pretty tight against the airway, if the turning of the patient's head or anything, secretions can flow down past the endotracheal tube and go down into the lungs. So getting rid of that secretions routinely will help eliminate that problem. And there's there's ways that if you don't have this special subglottic suction, there are ways within a thinner catheter that can go down and retrieve any secretions that are down there on the top of the cuff. So these are another way. Again, they're more expensive than the normal endotracheal tube, but they are available, and that does help reduce VAP. Mobility. It's so important, mobility. Passive range of motion is, as a nurse function. So moving your patient, turning and positioning minimally every 2 hours, using bed technology if available, beds that turn patients, getting them off pressures, moving secretions side to side. So your lungs should not stay in one place or else they will develop pneumonia. So there's beds that can put them in a full sitting position. So you should collaborate with physical therapy. And if you can potentially mobilize your patient, getting them out of bed into a chair or even walking, depending on their clinical status and the hospital resources, encourage patient to participate in this care as much as possible. They'll probably look at you strange when you say, oh, we're going to get out of bed or walk, but the more they are mobile, the faster they can come off the ventilator. Good nutrition is important to promote healing and address increased metabolic needs. So you really should involve a registered dietitian early to ensure adequate, appropriate calorie and nutritional intake. Internal feedings is always preferred as long as the gut is working, and if you have any kind of mobility and you have a gut, use it or you'll lose it. There's much more complications with TPN rather than just using tube feedings. Transport. Transport is a very high-risk time for incidents to occur. The number of people that have transport can be determined as how critical the patient is. But you have to ensure that the lines and the tubes are protected at all times and try to limit the transport as much as possible. So this requires extensive coordination, communication, and setup. The receiving area and the respiratory therapy all need to know when you're going and how long it's going to be there. You may have accompanying personnel, a minimum of 2 staff, which would be the RT and the RN. Equipment, you're going to need monitoring equipment, so you need the monitor. Again, hospital-specific guidelines, so not only the cardiac monitor, you may need pulse oximetry, you need a portable ventilator, you need a BMV or ambu bag. You may need some patient-specific items such as medications. So these are all things that when transporting, it can be very difficult and very stressful. The unexplained extubation. Patients intentionally can self-extubate, or the ET tube becomes dislodged or removed during care. Your priority nursing action is to provide supplemental oxygen, discontinue or any continuous sedation or analgesia, assess the patients for spontaneous respiration. So, let's see what their effort is, and if there's any presence of stridor. We prefer to deflate the cuff before they take out the tube, but if that's not their agenda. So you also want to call the RT and provider. If needed, you may have to provide assistance with ventilation and prepare for reintubation if needed. So these are all important things if the patient becomes extubated unplanned. Some patients are okay and they can remain extubated. Other ones you may have to prepare for intubation or see if maybe BiPAP might help them just to get over the hump. Sedation. So this purpose is to treat anxiety, improve ventilator synchrony, to improve oxygenation. It's best to start with intermittent dosage, like a Versed, Ativan, and if it's unsuccessful, you would probably want to put them on a continuous infusion of Propofol, Precedex, Versed, Ativan. Usually you'll see a protocol, a hospital-specific protocol or order. When sedation is not, decreased spontaneous respirations, if it's not enough, then you may have to have a neuromuscular paralysis may be necessary to control ventilator synchrony. So this will help with facilitating oxygenation. And again, you want optimal ventilation as well. So you need to be able to oxygenate and ventilate that patient to have adequate oxygen and CO2 exchange. So with all neuromuscular blockades, it stops skeletal muscle movement only. It does not control pain or sedation. You must administer some type of sedation and pain medication. It would be like being paralyzed in bed and being completely aware of everything that's going on and feeling everything done to you. So just because their eyes are closed and they can't move, they can absolutely be aware and feel everything that you're doing to them. So it is very imperative that you administer some kind of sedation and pain medicine. There's different types of neuromuscular blockade agents. I'm just going to kind of quickly go through them. So Rocuronium is used to relax muscle. It works by blocking the signals between your nerves and your muscles, which is basically what all of them do. I'm just going to give you some quick loading doses and some tips about each of them. So the loading dose for Rocuronium is 0.08 to 0.1 milligrams per kilograms over 60 seconds, and then you can have a continuous infusion of like 0.001 milligrams per kilogram a minute. And again, that can be started 20 minutes post-bolus. So your maintenance can be up to 0.0012 milligrams per kilogram a minute. The one thing about Rocuronium is that it has a less cardiovascular effect than panacorin or Tracheotomy. It does have hypersensitivity, so you can have rash or some anaphylaxis, but that can happen with any of your neuromuscular agents primarily. The next one, Tracheotomy. A dose of Tracheotomy is about 0.4 to 0.5 milligrams per kilograms. Again, they have the potential for allergy reactions such as skin flushing or redness, itching, hives, histamine because of the histamine release. Now, this can cause a lower blood pressure or a fast or slow heart rate. Nimbex, compared to other neuromuscular blockades, it is intermediate in its onset and duration of actions. So Nimbex is not recommended for rapid sequence endotracheal intubation due to the time required it takes for the onset. But it can be used in conjunction with Propofol, and it's recommended started weight-based. So Nimbex is between 0.15 milligrams per kilogram and 0.2 milligrams per kilogram administered by bolus IV, and an infusion of 3 milligrams per kilogram a minute, and that range usually is about 0.5 to 10.2 mics per kilogram a minute. Some of the side effects of Nimbex as well as some bradycardia, hypotension, again, anaphylaxis due to the histamine release. It can cause a more prolonged neuromuscular blockade and causing muscle weakness and myopathies. And Nimbex has been associated with residual paralysis, so it is important to monitor train of 4 to ensure the blocking isn't not too high. Rocuronium is a blocking agent with a rapid to intermediate onset depending on the dose and intermediate dosing. So it is 0.6 to 1.2 milligrams per kilogram, and it is good for intubating conditions to most patients in less than 2 minutes. There's a maintenance dose of 0.1 to or 0.15 or 0.2 milligrams per kilogram. And choline is a short procedure, usually 0.6 milligrams per kilogram IV injection, and this can be done as a continuous of 2.5 milligrams a minute infusion. So this dose should be calculated based on ideal body weight. Again, these patients oftentimes may have to be pre-treated with atropine, which may reduce the vagal-mediated bradycardia and hypotension and drooling that can occur. Again, so adequate ventilator support, mandatory, and may experience another increase in sensitivity with electrolyte disorders as well. So hypermagnesium, hypokalemia, hypocalcemia. So that can also have that effect. And with that hypocalcemia, it can also have higher incidence of malignant hyperthermia. So if you have any kind of neuromuscular blockade, you need to do a train of 4 because long-term use of neuromuscular blockades can result in prolonged paralysis and the inability to wean and skeletal muscle weakness. So to avoid this complication, the patient's level of paralysis must be carefully monitored with a peripheral nerve stimulator. So it depends on the number of correlated twitches with the level of paralysis. So you make sure to correlate the patient with the train of four. So if the patient is moving and you are not feeling any twitches, there is a problem. Include the device malfunction. Poor electrode contact can be the cause, or improper electrode placement and edema. So, and if you have it in an area that has a lot of edema, it's not going to work properly. If at all possible, get a baseline of train of four prior to starting on neuromuscular blockade infusion. And again, the peripheral nerve stimulated purpose of monitoring to optimize therapy and decrease adverse effects. And it delivers an electrical stimulus to the pre-selected nerve by electrodes, and the response is monitored to gauge the level of paralysis. Typically, the electrical stimulus is train of four nerves to be used as the ulnar and the facial. And the electrical stimulus can be delivered by different types of electrodes, either ball type or pre-gel. So the goal is to titrate, maintain a 2 to 3 twitch, which would give you 80 to 90% blocked. If you have 0 twitches, that means you're 100% blocked, which is way too much. So you also in some facilities will do a BIS monitoring, which is bispectral index monitoring. It's basically an EEG. And it's monitoring the waveforms. It varies from 0 to 100, with zero meaning no cerebral activity, where the patient is fully awake. So no cerebral activity to the patient is fully awake at 100. So if you have a patient that is being sedated or is on a neuromuscular blockade and you want to know how aware they are, you can look at the number. So 90 to 100, the patient is awake. 70 to 80, they're considered conscious sedation. 60 to 70 is deep sedation. 40 to 60 is general anesthesia. So the other thing is the waveform confirms the value. So use them to monitor levels of sedation in patients receiving those neuromuscular blockades, and so that you know that if your patient's awake, they know everything, they feel everything, and they're paralyzed. So be conscientious of what your hospital's policy and protocol is for your BIS monitoring. So for daily weaning readiness screening, so every hospital should have a specific weaning and extubating parameters. Typically, you should have an FiO2 around 40% or less. If it's greater than that, then that means that the lung is not healed correctly if it still requires so much FiO2. Also, PEEP of 5 or less. And again, if it's higher than 5, then the patient's lungs are not healed enough. Patients should be able to be awake and have spontaneous respirations. So you'll usually use a gradual withdrawal of ventilator support from full support to intermediate support to a weaning. And again, you want to always assess the patient's baseline vital signs of level of consciousness, their ability to take in a breath, their physiological and hemodynamic stability, and whether they have a diaphragm or not. So if they have an adequate diaphragm, which they can pull air in, some respiratory therapists will use what they call a NIP, which is a negative inspiratory pressure, and it can determine how strong the diaphragm is to pull in air and give you that negative pressure. So there's different ways to determine if that patient is ready for weaning. So if they are weaning, you want to sit them upright. Make sure that there's suctions, there's nothing in the back of their throat. Educate patient and family, explain the process, offer reassurance, and sometimes if you can divert their attention and give them diversional activities, whether watching TV. Again, always get baseline vital signs and level of consciousness. And usually you'll see different physicians' preference for method of weaning. So you have your T-piece, your SIMV, your PSV, your CPAP. So these are all things that, for different providers may have different ways, their favorites for the weaning patient. So if your patient is in the middle of weaning and you're monitoring them, and then they might be failing. So how do you know? You oftentimes will see paradoxical breathing, which is your chest and abdomen is going asynchronous. You'll see signs and symptoms of tolerating weaning when their blood pressure is elevated, their heart rate's elevated, the respiratory rate is elevated, their dysrhythmias, they may be having PVCs or going SVTs. They have a decrease in oxygen saturation. They're restless, agitated. They're paradoxical breathing. They have a decrease in level of consciousness, or they're restless or anxious. They may have ST changes. They're using accessory muscles. They're complaining of dyspnea, fatigue, or pain. And they're diaphoretic. So these are all things. You don't have to wait for all of these to occur before you decide, oh, they failed weaning. If they're really struggling, then you should call respiratory therapy and have them return back to the full support and let them rest on the ventilator. So if they're ready from weaning to go to extubation, you want to emphasize that they are going to be breathing on their own, that we're going to be taking out the tube. And remember, the nurse does not usually extubate. Usually it's a physical therapist. You may work as a team to do it, but for the most part, the respiratory therapist will come and do it. You can be there because you want to monitor the patient as well. So stridor is the physical sign, or a high-pitched wheeze of, when you have an upper airway that's narrowed or obstructed. So that's one of the key things you want to monitor for is stridor. And that is considered a medical emergency and usually treated with nebulized racemic epinephrine and decadron, which can resolve the stridor. If you haven't used racemic epinephrines, the difference between regular and racemic epinephrine is the molecular structure, where racemic is given in a nebulizer and it has more sustained action and prolonged results. And so the respiratory therapy extubates. They suction the mouth out and the ET prior to removal. Have oxygen ready. It usually should be humidified mask. And again, you're assessing the overall tolerance. And if needed, that be prepared that the patient may require BiPAP or reintubation. So you want to do frequent assessments, assess for stridor, and these patients usually should be monitored in ICU for 12 to 24 hours post-extubation, or sometimes when the bed is needed. But for the most part, it's good to monitor them for a while after extubation to make sure that they're tolerating it well. That concludes the mechanical ventilation lecture, and thank you very much.